So a population perspective on artificial intelligence, and I've broken this talk into 3 sections. First of all, a little description about population health, just to make sure we're all understanding that concept in the same way. And then I'll spend most of the presentation going over some opportunities and examples from my research in terms of the application of different types of artificial intelligence to different problems in population health. And then I'll close with some challenges. So first of all, population health, maybe just a quick show of hands. Who has a good working definition of that term in their heads? A few. Okay, a good number, okay. So there's a number of ways of thinking about population health. The way I like to think about it is that, as the name suggests, it's interested primarily in populations, not in individuals. And so what's immediately apparent when you have a population is that not only do you have the health of an individual, but you've got an average health of a population, and you've got some distribution of health across that population. And that distribution immediately brings to mind the thought of, is that health equitably distributed across the population? So population health is really, in a sense, the crux of starting to think about equity in terms of health, because we're looking at how, and it depends on what you're looking at in terms of your measure of health, but how it's distributed across the population. Also, pretty important for population health perspective is it's longitudinal. So you're really taking a long-term view, if you will, thinking about upstream factors that may influence the health of the population, and immediately you come to think about things like prevention in that context, which often can be cost savings from a population health perspective. You might think of a whole population. This is an example, a map showing the whole United States population. Or you might think of specific subpopulations. In this case, it's showing inequities in distribution of mortality, actually, across the United States, that particular map. And when public health is another term that, of course, you've heard of, and public health really takes an organized societal approach to improving and often protecting population health. So those are just some terms. In terms of what actually drives population health, this is a famous model that came out of Canada, which really started to think about in big boxes, what are really determinants of population health? So if we really think about a population, like Montreal or Quebec, for example, what is making people in this population healthy or not healthy? As you can see, there are a number of factors in this original diagram anyway that were shown to link towards suggesting what is actually driving population health. And if we go even farther back, you can think about the Ottawa Charter as actually a way of starting to talk about forces or fields that influence health. Some people have actually tried to put numbers on some of these determinants. And so this is one example. It came from an article in 2014 in Health Affairs. And most people are quite surprised to see that only a small part of that pie chart is medical care, the 12% at the very top, whereas a large part of what influences, and this depends on your outcome you're looking at here, we're looking at mortality here, we're talking about things that here are called behavior, although now we know that it's not really individual behavior that influences a lot of these things, it's the environment they're in. But nonetheless, as you can see, if we really want to modify population health, we have to take a step usually outside of the hospital and outside of clinical care systems, because the vast majority of what's determining people's health in a population is not happening in those clinical environments, okay? So this is another important perspective of population health, is that we understand there is an importance, certainly for healthcare systems, but we have to think more broadly than that if we really want to move the needle on population health. So where does AI fit in here then? Well, lots of possible ways, as you can see, and you've probably also seen in your experience. One immediate thought is that AI can be used certainly to define your populations in terms of clustering or segmenting the population to look for components of the population that might be more amenable to one intervention or another. Also, many applications where AI has been used to measure and predict. And the things we usually think about measuring and predicting in a population context: health determinants, so what causes the causes of health, health status, as well as health outcomes, which are often more the downstream consequences of ill health. And more recently, we're seeing applications of AI to try and integrate large amounts of information and evidence about populations to guide decisions, again, not about treating individuals, but decisions about interventions you might do in a population health setting. So one, I guess, framework that's come up recently is this concept of precision public health, and you've probably heard of precision medicine. So this is the concept that's been floated at a public health level, and there's been some debate in the literature about this. There's a couple references there recently that were discussing this topic. And the thinking here really is the idea is that we really want to be able to bring some precision to identifying, as I mentioned, those subpopulations, and AI can be quite useful for that in large amounts of data. And what you're seeing here is a map where they've done some very sophisticated mapping of under 5 mortality in Africa to try and really guide not just a generic strategy for how you might address under 5 mortality in low and middle income countries, but really to hone in on specific areas where they're seeing specific differences and try and bring in targeted solutions in those areas. So there is a potential, this is like a framing that's kind of nice in some ways for thinking about AI applications in public and population health, although there are some drawbacks, and we can discuss this framing afterwards if people have questions. Another framework that I find useful, which works in, I think, clinical and in population health, is this framework that looks across the top at how much kind of guidance or insight are we getting from an algorithm, from an initial prediction of a probability to a classification or a threshold of probability, to advice to say you should do something, to autonomous action. As you go farther down that road, you're getting more and more, if you will, dependence on an algorithm. And if you go down here, we're looking at different health contexts. So from a population health perspective, the diagnosis is really about measuring health status in a population, trying to understand the needs. Interventions, trying to figure out what we should do in a given population, and operations might be more just the day-to-day management of population or public health services. And you can think about how different boxes here might be filled in by different types of applications or studies. Most of the work that you'll see and most of the work I'll talk about is really towards the left, more in the prediction space, although we're starting to get a little more into the classification and advice space. So that's kind of a big picture about population health and sort of generally speaking some frameworks about how AI may fit. Now I'm going to go through not just, but 4 areas where we've done some applications of AI in a population health setting to give you a flavor for what these look like. I'm not going to get into the deep technical details, but I'm happy to discuss those if people have more specific questions afterwards. So the first area is nutrition. And I don't know if people have seen this representation. This comes from the Global Burden of Disease study. And this is for the leading causes of disability and premature death in Canada, looking at the behavioral and other risk factors driving the leading causes. And so you can see there was some stability in 2007, 2017. Some of the most important risk factors, if you will, are really linked to or influenced by nutrition. And so in a lot of the research that we've done, we've noticed that this is really a critical risk factor from a population perspective, but we have very little data about it. We do surveys primarily, and we tried to look for other ways to see if we can measure nutrition at a population scale. So one thing we've looked at is this food purchasing data. And as you probably know now, it's very hard to buy anything without it being scanned and causing a beep and it going into a database somewhere. So really pretty much in all grocery stores, pharmacies, corner stores, big box stores, they're scanning the food you buy. There are different ways these data get aggregated. There are large companies like AC Nielsen, for example, which actually buys that information from stores, then repackages it and sells it back to both retailers and manufacturers to help with their marketing. And then within some larger stores, they also have loyalty card programs where they aggregate their data themselves and link it to loyalty cards so they can analyze those data. So we looked at both these types of data and to see what we could use them for from a public health perspective. So in the first example, we did some work looking at sugar-sweetened beverages, and this is work that was done primarily by a PhD student of mine, Hiroshi Mamiya, along with other collaborators shown on the screen. The part of this research I want to highlight for you is that this is the data set, just to give you a sense of what we're looking at here. You can see on the bottom, actually, of this slide is the kind of transactional data that we can get. It's actually grouped at a row level, so it's not every single sale, but within every store that was sampled, we would get all sales for a given product over the course of a week, along with the price and other characteristics. And this is sampled in a way that is representative, so across multiple stores in Quebec, and we were able to buy a number of years of data with research funding. And so the question that we were trying to get at here is one of the strategies that's been put forward to influence people's purchasing of sugar-sweetened beverages is taxation, essentially taxing sugars. And we know from other products like tobacco that taxation does have an effect, obviously, on purchasing, especially in people that are more sensitive to price. However, with this taxation of sugar, there's not been a lot of understanding of how price really affects purchasing, especially across multiple categories at once. So if you increase the price, for example, on sugary drinks like Coke, does that just mean people start to buy more apple juice? And so what we wanted to do here was to look across multiple multiple types of sugar-sweetened beverages at once and understand if a taxation was brought in on sugar-sweetened beverages like pop, what would happen? How would that change the purchasing? And so this is, in a sense, called cross-product elasticity. But the space of this data is very large, and so we could not really do this very well with traditional regression modeling. So we did look at traditional regression modeling, which is the lasso row there that you see, which is a type of logistic regression. But we also looked at two other types of machine learning methods, boosted trees and deep neural networks, to see to what extent we get an accuracy in predicting the actual purchasing from price changes, accounting for price changes of all related products. And I won't go into great detail here, but this is sort of a traditional machine learning presentation where you bold your algorithm and show it's better than the others. And what you can see actually is, in terms of mean square error, a pretty significant decrease in terms of our ability to predict pricing by taking account of the broad range of products that were involved in that product group and not just looking at one product at a time. And what this allowed us to do even more was actually do store-level prediction. So each of these lines now is a store, each one of which has a different mix of items in the store and also has different socioeconomic characteristics around the store. We also found, for example, that the average education in the neighborhood around a store also influenced the response to dropping the price of sugar-sweetened beverages. We saw a higher uptake in purchasing of sugar-sweetened beverages in neighborhoods that generally had lower education. So in this sense, we can get a more nuanced sense. If we were, for example, to change or bring in a taxation to affect the price of sugar-sweetened beverages, what kind of change would we expect at a store-by-store level in terms of the uptake or purchasing of those products? So that's one example of how machine learning really allowed us to, in a sense, harness a larger data set than we would have otherwise been able to use with traditional regression models and gain some insights that were a little more targeted in terms of understanding what would likely happen if that kind of a tax was brought into practice. Looking again at another type of nutrition data, these are now data not at the store level, but data now where we have entire baskets which are linked to loyalty cardholders. And so this was work by a student, Cody Crowell, who just graduated with a master's thesis. So here, what we had, as I mentioned, was data from one entire retail chain, all their stores, all transactions. Those transactions were linked to an anonymous loyalty card, which we didn't have any information about who those people were, but just allowed us to link the basket over time. Very large volume of data, over a terabyte of data. We have 1.4 million cards, hundreds of millions of baskets, and billions of transactions. And so what we want to look at here are two things. First, we started just looking at some temporal trends, which is not terribly artificial intelligence, but brought some interesting insights from a public health perspective or population health perspective. What we're showing over, you can see the labels perhaps. At the bottom, you can see the legend. But what we're showing is over time, in the middle of the plot there's around May of 2016, you can see a drop in purchasing of soft drinks, which we know is happening in a trend in terms of the population. People realize that there's sugar that is not good for them. But unfortunately, what we're seeing is an uptick in the black line, which is juice. So people are at a population level kind of substituting, it would seem, one for the other. But what's exciting about these data is we can dive right into the baskets, and we can actually see how people are changing their purchasing and also what they're co-purchasing. And in fact, this was the question of my master's student was, does something like a taxation on sugary soft drinks make sense? Is it really the one thing in the basket they're buying that's the problem? Or is it really a pattern of purchasing that is more an issue? And so in fact, it was really more the latter. So this is just looking, using association rules, which is a type of machine learning. He wanted to see what items are commonly co-purchased in the same baskets. And you'll see, in fact, interestingly, that fruits and vegetables are some of the more commonly purchased things together. But as we get down, and this is just showing the two items, as you expand into larger items, the bottom line from this analysis really was that rarely did you find a basket full of healthy things and then sugar-sweetened beverages in the basket. And that probably doesn't come as a shock to anybody, but it does reinforce the potential limits of a policy of taxation of single food items, when really what we need to do is probably change the overall composition of people's food baskets. So anyway, a bit of a data-driven example in nutrition. So those are two examples in nutrition of how we tried to use machine learning to get a little deeper inside large data sets that would have been very challenging to look at with traditional kinds of methods. The next example I want to talk about is thinking about what kind of interventions you might implement in a population. So for a number of years now, we've been working on a project to create something called a population health record, and I'm showing you a few different screen grabs from that application here. The idea of this application is, as you can imagine, in a clinical setting, a physician has an electronic medical record. And that electronic medical record, one of the main purposes of the electronic medical record is to integrate information about a single patient. So laboratory data, pharmacy data, drugs that have been prescribed, all is organized around one patient. The population health record concept, which is not one that we created, but the idea is to create something like electronic medical record for population health. So we want to integrate all the information relevant for population health around a defined population. And we use that determinants of health framework I showed you before as kind of a framework for how we organize that information. Now here we're using a different type of artificial intelligence, or branch of artificial intelligence, something called knowledge representation. So what we want to do here is, because there are hundreds, if not thousands, of these indicators of different determinants of population health, we want to help people understand how these indicators or determinants do or do not relate to one another in terms of driving the health status of a population. So what we do is we formally represent in logic using something called an ontology, which is a representation of knowledge that both humans can look at and sort of understand, as you can probably look at that diagram and see some relationships. But more importantly, a computer can take that and can actually process it and can, in a very decidable way, come up with solutions that are correct. And so we use this knowledge primarily to link risk factors to diseases, and then use that information to organize information. And so, for example, what the application, one screen of the application would show you would be what we call a causal diagram. And so this takes a small snippet of that knowledge. Somebody's asked a question about physical activity, and we're showing downstream consequences of physical activity and upstream causes of physical activity, and then we can layer indicators over those concepts for a population. So this is one way to use formal knowledge representation to help somebody arrange indicators or information about a population. And we can go even farther by saying, here in this particular presentation, we're showing in the top now a map for obesity for all the health regions in Canada and a time series for obesity. And the black line is obesity for all of Canada. And we've selected one particular region from from Newfoundland, it looks like. And that's the teal line you see on top. You can see in that particular region, they definitely have a higher rate of obesity than the Canadian average. If you go down now to the bottom half of that screen, we've gone to that knowledge representation again, and we're showing all the indicators on the left that are driving obesity and all the indicators on the right that are downstream causes of obesity. And this particular region is highlighted as the green dot. So you can see all those dots, there's one for every 120 odd health regions in Canada. So you can see for this particular region, they are the worst in Canada in terms of sedentary lifestyle. Interestingly, they have the lowest stress, but they're pretty much the worst on every other indicator. And so what this allows you to do is really understand, not in an average way, but for this particular region, you can see what we think are the factors that are driving obesity, what we think are the consequences, and as you'd expect, you're seeing those patterns really show up in the data for this particular region. So again, if we think about this concept of precision public health, we're now really painting almost like a phenotype or portrait for this particular geographic region and population in terms of what's driving that issue of obesity from a kind of causal perspective. So our plans, which we're working on now in terms of ongoing research, is to actually be able to take that information, which you sort of see in the bottom left here, that defined information about a population by where the purple circle is, and we want to bring together with that evidence about what interventions you might want to do in a given population. And so going back to the precision medicine analogy, the idea is you've got an intervention that's perfectly tailored or connected to that individual to get the best outcome. What we've done is we've created an interface to a repository of public health interventions called Health Evidence. And so our system literally has a computer interface to reach out to that system. And when you're looking at a given population like the one I showed you, we can actually send characteristics of the population in a query to get back interventions that seem to have been shown to be effective in similar populations, and then ultimately show those to individuals. Ideally, we could actually estimate the effect of that intervention in that population, but that's something that's going to take a few more years to get to that point in a fully or even a semi-automated way. So this is really us kind of trying to think about, again, for bringing that precision idea to population and public health.
Sorry.
Yep. Sure, go ahead.
So which are the features that you're using in order to do this matching?
So there's features are characteristics mainly of the population, so age, sex, level of deprivation. I mean, the challenge really is, can we get that sufficient amount of information out of that population, and can we actually sufficiently extract it from the evidence? So I didn't really get into the evidence pipeline. Right now, that's a manual pipeline. It's semi-automated, but there's a whole nother stream of research to use natural language processing to try and pull more structured evidence out. Ultimately, I mean, there is a theory of transportability behind this, which is actually sort of a data fusion strategy, which is also where that matching ultimately has to go to. So it's really not, I mean, you can think about it as a matching and a similarity problem, but ultimately it's going to have to be more than similarity. It's going to have to be, can we actually, is there sufficient overlap between the population you're trying to do this intervention in and the populations that we've actually studied this, that we can actually take that evidence and apply it to this population? So we've done some very detailed work in areas like influenza vaccination. And it's fairly clear the evidence and the information is sufficient in that subdomain. There will be other domains in public health, like health promotion, for example, which will be much more nuanced and less quantitative. It'll be harder to do for sure. And I should say, if there are questions, please do interrupt. Or don't interrupt, just if you're not interrupting, just ask, be happy to chat. Okay. So the next example is global surveillance. So the WHO is in the process of renewing this approach to event-based surveillance, which is something actually that really was pioneered in Canada in a system called GFIN, the Global Public Health Intelligence Network. And the strategy here is to say that the reporting for health events is a relatively slow process. Generally, it comes from a local health authority to a regional health authority to a national health authority, and then through the international health regulations onto the World Health Organization. That process can take weeks or months and can even be actively suppressed by some governments. So about a decade or maybe even longer ago, the idea was, well, why don't we look and see in online media? So in newspaper and other reports that are published online, if we can actually glean information about infectious diseases, but also other types of public health emergencies. And so, in fact, what Canada built was I would say, a semi-automated system where there's a very sensitive filter that goes out and reviews hundreds of thousands of media reports pretty much every week, pulls those into a room which has about 10 multilingual analysts who review those and determine whether or not they're important, write briefs, and then they move on. As you can imagine, this whole process could be automated. And in fact, a number of countries around the world have now started to develop automated or semi-automated systems for sort of combing through that media, identifying events, and pulling them together. And so now the WHO has created something called an EIOS, or Epidemic Intelligence from Open Sources, which is like an open aggregator across all those different screening systems, pulling information in together. And this is a screen showing you that. This is one screen just from today where it's showing we have a new first case, or first death actually, from flu in Texas, picked up quite quickly. And as you can probably see, it's got a very small number of tags where it's tagging and saying this is influenza with unknown virus. It's tagging it to be in Texas. But the amount of sophistication, I would say, of the natural language processing so far is not terribly high. And so, in fact, I just came from a technical meeting with WHO where they're really pushing now hard on a strategy for how can we actually advance this and make it better. So one area is really to get much better natural language processing, to sort of smooth or go through those really large numbers of online media reports with higher precision and recall in terms of getting out information that you really want. Being able to extract entities like disease, for example, more accurately. Even geography can be very hard to extract. Are we talking about Victoria in Canada, in Australia? Sometimes it's very difficult to know exactly what location it is. So there's a fair bit of work going on in the NLP, which is not the area of expertise of my research group. Where we're involved more, though, is being able to take the results of that processing and now do some interesting things. So now we have thousands of reports which have been parsed and have had certain entities detected. Now we want to try and cluster those reports together to find meaningful events. So if we have a whole bunch of reports talking about influenza in different ways, can we link those together and say, yes, this is all talking about one particular outbreak, and somehow give people a more summarized view of that, and then ideally be able to assess how important that event is. Now, is that something that's a machine learning strategy, or is it an automated reasoning strategy? It really depends on how much data we have. But if anybody's interested, we're looking for a postdoc on this topic, so just let me know. Okay, the last example I'll give you before just closing with some challenges is clinical populations, which may be closer to some of your experience. I like this diagram because it's a bit organized in a way to give the impression of an iceberg, but I think that's the impression that's a good one. So what it's showing is across the top for a set of patients, their claims data in green. And so claims data are insurance data that are used to basically for physicians or drug providers to get paid back essentially for giving services. So these are the data in Quebec that the RAMQ holds primarily and Medeco. Going down in brown are the clinical data, and every line, if you will, every column is a person. So as you can see, the depth of those clinical data are much richer, if you will, than the claims data that we traditionally have access to. And even better, if you can bring those two together and link them, the claims data generally give you a fairly complete story of somebody's trajectory through a healthcare environment, and the clinical data give you very rich data underneath it. So as you may know, different academic health centers in Quebec have been working fairly hard to get their data organized and accessible. I know at CHUM Citadel is in place, which facilitates access to those data. At the MUHC, we've just opened about a month ago now a data warehouse, which brings together data for around 20-odd different systems for over 4 million people. And so far, we already have something like 30-odd requests that have been pulling data and analyzing them within an environment at the hospital. So this is a different kind of population. It's still a population, and we can still think about how do we best manage hospital population. And some of the work that we've been doing is really to try and look at how we can look at detailed time-varying patient trajectories to cluster different subgroups of patients who may be responding well or not responding well to different types of therapy. So just as an example, one of the areas that we've worked a fair bit in is extending continuous time hidden Markov models as a way of modeling people's movement through different latent stages of a disease, in this case, chronic obstructive pulmonary disease, as a function of their observable clinical and claims data. And here I'm just showing you two examples of two patients of different ages. And what we're showing in the bottom half of each of those plots is that we've recovered from the model their movement through these states, with the higher states representing a more ill state, if you will. And what we're showing is just one of the data outputs at the top, which is the total number of medications that are prescribed, which tracks actually fairly closely with having a more severe state of COPD. This is just one example, though, and I think there are many examples you can think of, both in terms of population health management, but also in terms of operations within hospitals that can also be benefited greatly from applications of artificial intelligence. Okay, so I'll just close with a couple of challenges, which I think are probably pretty aware for most of you, but the first one is data access. So in population health, by definition, you want data on the population. And so to the extent to which you can't get data on the full population, you can't really ask meaningful questions about that population. And so obviously we have to be very careful about privacy and protecting patient privacy. And what this is showing is a slide from the Globe and Mail article last week, where it kind of leaked, I think, that Ontario is thinking about how they can make their health data, their claims data, more available to researchers and possibly companies, because there's a lot of interest in having access to these data. And as I mentioned, some would even argue that if you don't have representative data, you're not actually doing that population service, because whatever population is not represented in your data set is not going to really be able to benefit from whatever innovations or advances you make through your research. So when you think about machine learning algorithms, one thing that's often talked about is bias in learning. So if a certain subpopulation is just not included in your data set, you learn a predictive model, say for diagnosis, that person shows up at the clinic and you make a prediction about that person. Well, they're really completely out of that data set. So that model really knows nothing about that person, and we don't know how well it's going to perform, but we can almost guarantee it's not going to perform as well for that person as if their data had been included in that learning data set. So data access is, even though it's a problem for all types of artificial intelligence who want to make say a clinical contribution, I would argue from a population health perspective, it's even more troublesome if we're missing subpopulations. We're trying to learn models from the data. And a related but sort of different point is value alignment. I don't know how many people saw this paper. It came out in Science about a week or so ago. Okay, well, I'll give you the quick summary. So this is a predictive algorithm used widely in the United States. I don't think it's used in Canada, But essentially it's used, but similar concepts are being used in Canada, I've seen them explored, to try and predict the high flyers, the people who are going to spend the most money or cost you the most money in the next year, okay? So this is a classic algorithm used in healthcare systems in the United States where they try and use this algorithm. They feed it all sorts of claims data in terms of visits and cost and so on. And what they're really trying to predict is what's your cost next year. So next year, how much healthcare resources are you going to use? And then they use that index that comes out of it to actually make an intervention. People who are going to cost more at a certain threshold, I think at 97.5%, which is at that very line at the very far right, the dotted line, they will actually take dedicated personnel and assign them to those patients to try and guide them through the system and help them to minimize their costs and hopefully have better health outcomes. So what these researchers did in this paper is they went and they worked with the academic health center. They got access to the inputs to the model, the outputs to the model, and they also got access to additional information. And in this case, the additional information was the race of the people. And so they just focused on black and white because they couldn't look at other races so carefully in this data set. But that was not actually available to the algorithm. So this algorithm was perfectly calibrated from a machine learning perspective. It was just great accuracy, great calibration. But what they're showing you now is when they stratify the results by black, which is the purple line, and by whites, which is the orange line. And so what they're showing you is that at a given threshold of this model, black people are significantly sicker than white people. Or flipped around another way, at a given level of illness, black people tend to be using far fewer and less costly resources than white people. So what this algorithm basically had the effect of was taking far more of that intervention and pushing it at white people at a given level of health than at black people, and therefore making that inequality even greater. Now, is that a problem with the algorithm? Not at all. The algorithm is fit perfectly. The data set is perfect. The problem is the choice of the objective function. What they're trying to maximize is cost. And it's pretty clear if they'd thought a little farther upstream that there are these inequalities in terms of who gets access to care and actually takes advantage of that access to care. And there was known to be a fairly large difference between whites and blacks. And so this reinforces that. So the solution here was not better modeling or different data necessarily. It was a different objective function. They shouldn't have tried to optimize cost. They probably should have tried to optimize cost over some healthcare measure. But again, this is also a function to some extent of the United States healthcare system where this probably made perfectly rational sense from a for-profit hospital perspective because they're trying to control costs. But as we think about how these kind of algorithms get baked into population health thinking here in Canada, I think it's really important to think about not just the biases from learning, but being very careful about those objective functions. So to summarize, AI and population health, think about not just the mean, but the variance. We want to ideally improve everybody's health, or the average health, but also decrease that variance around that health improvement. I've shown a few examples of population health applications of artificial intelligence in the commercial data space, where we've really used machine learning to try and take advantage of those really big transactional data sets. More in the field of public health interventions, where the data are a little less sparse, but we're trying to use more formal knowledge representation to help us understand what interventions are most effective. In the global surveillance domain, there again, we're talking very large amounts of data. So these are more machine learning, unsupervised clustering models. And then finally, clinical populations, again, where we have this rich time-varying clinical data, and we can start to think about very interesting time-varying prediction and clustering models. The challenges, I just highlighted two. There are others, of course, but I don't want to sound pessimistic. There are many opportunities. And finally, I'll just close with a couple websites, and by also pointing out, if you have an interest in learning more about AI and public health, we were fortunately recently funded by CHR to start a summer institute in AI and equitable AI and public health. And the first event of that will be actually this summer in Montreal, so stay tuned. I'll be tweeting about that, and you'll be hearing more about it when that's open for business. But that'll be running over the next 5 years in partnership with CFAR and the AI institutes here and across the country. So thank you very much.